did tell you that we'll have Dr. Alex Oko here with us this morning, and also Professor Bazoaye Nusa, a hematologist and consultant, and with the University of Benin Teaching Hospital. Gentlemen, you're welcome to this program this morning on ITV.
Thank you very much.
Yeah, well, we're going to be using one stone to kill two birds, just as it's popularly said. Today is World Pathology Day and also World Diabetes Day. And it will amaze you to know that about 423 million sufferers of diabetes die annually as a result of diabetes. And it's also alarming to know that it's almost an ailment that is ravaging people here and there because of their lifestyle, because of hereditary factors and all that. Gentlemen, you're welcome one more time.
Thank you.
When we talk about diabetes, Dr. Alex Oko, what exactly do we mean?
Well, thank you very much, Evans, for bringing me to this program. It's very important that we enlighten our people more about the disease diabetes, because the prevalence has shot up in recent times. But let me quickly correct the opening statement. That what we have is 425 million people living with diabetes, not have died from diabetes. Yeah, and that's a global figure. Suffices to say that Nigeria has a very huge chunk of that figure. Or in sub-Saharan Africa, Nigeria has the largest number of diabetic sufferers.
Nigeria?
Yes, Nigeria. Maybe against the background that we are the most populous country in Africa too. So when we talk of absolute numbers, Nigeria will always feature very high, especially in Africa. The reasons are not far-fetched. Diabetes is a disease, it's a metabolic disease that results from a metabolic derangement. The body is unable to control the sugar content or level in the blood. That arises from several factors, mostly arising from the weakness or non-optimal function of the pancreas. That could be adjudged to a number of reasons. Lifestyle, like you have said, hereditary, environmental, and all that. But suffices to say that not every time you have a high blood sugar, then you say the person has diabetes mellitus. Diabetes mellitus is diagnosed when the elevated level of sugar in the blood is persistent. Something we call chronic elevation of blood sugar. And when you say it's persistent, that means over a period of time, repeated assessment of the level of blood sugar remains above normal. Then you say this person is likely to have diabetes mellitus. There are other factors that will come along with, that sign before you label the person as a diabetic. Okay.
Now, Dr. Bazoaye, Professor Bazoaye, I beg your pardon. Now, pathology as a special arm of medicine, what does it really pertain to?
Well, a pathologist is a trained medical doctor who has specialized in laboratory medicine.
Okay.
You will say that the pathologist is a doctor who understands the process of a disease. He's also a privileged doctor that has the ability to bridge between the laboratory diagnosis and the clinical treatment. So the pathologist acts more like a bridge between the laboratory and the clinical arm of medicine. We have about 4 departments.
Okay.
I mean, you have 4 types of pathologists. You have the one that we call a hematologist, which is the one I am.
I'm a
specialist in hematology. We look at blood and blood-forming diseases. So we are the ones that look at sickle cell, we look at blood cancers, we look at bone marrow failures. When you talk about shortage of blood, the one that is called anemia. So the hematologist has the ability to look at laboratory results, to make them into reports. That means when you have a result coming out from the lab, he has the ability to look at it and marry it with the clinical features of the patient. And the hematologist has the ability also to treat. So take, for example, we treat sickle cell patients, we treat patients with blood cancer, and we also do bone marrow transplantation, which is what we do in UBTH. So that's hematology. You have the other pathologist that is called the chemical pathologist that looks at the biochemical factors in the body. Things like the ureas and electrolytes, how the kidney functions. Those are called chemical pathologists. And they also run what is called the metabolic clinic, where they work with the physicians who look at diabetes, for example. So they run the metabolic clinic. That's a chemical pathologist. The one that we call the morbid anatomist is the one that does things like histology, where we do autopsies. These are doctors who look at the reason why people are dead. That's what we call autopsy. Then they're also the ones who look at the ability to look at specimens and make diagnosis out of the specimen. So these are people we call morbid anatomists. And then you have the last group, which is called the microbiologists. Those ones look at things like blood culture. They look at other things like diseases that has to do with viral, fungal, and they treat people that have sexually transmitted infection. So the pathologist is, in summary, a bridge between the laboratory and the clinical section.
Okay. Now, Doctor, will come to you. Now, let me come to you to your own field, the hematology.
Hematologist.
Now, you talked about the sickle cell anemia, right?
Yeah.
Now, there has been this, should I say, myth, so to say, kind of misunderstanding now that the sickle cell anemia can really not be treated. Some say you cannot treat it, you can only, some say you cannot cure it, that you can only treat it. What is the exact position of that?
Well, that's, I think we've been in this program several times.
Yes,
sickle cell disease is a disease that can be cured by those who are working in the Department of Hematology. The first bone marrow transplant in UBTH was done in 2011. And since then, we've done a total of 8 bone marrow transplants for sickle cell, with their genotype changing from SS to AA. So we've had 100% success. We've done about 8 in these states. And as I said, sickle cell has a cure, and the cure is bone marrow transplantation, and it's only done currently in Benin, in the entire sub-Saharan Africa.
Okay, we're going to come to that. Now, Dr. Alex Oko, on diabetes one more time. You've tried to, you talked on, factors that could be responsible, hereditary factors, lifestyle and all that. Now, amongst these factors, which one can we really pinpoint our finger on so that our viewers out there should be aware and perhaps be mindful of this factor?
Yeah, the hereditary factor is what you and I can do little or nothing about. Whatever gene you are born with stays with you for life. But the environmental factor, the lifestyle factors are modifiable. Those are the factors we refer to as modifiable risk factors, while the genetic factors are non-modifiable risk factors. So for the modifiable risk factors, that is where we center our prevention and control on. Those ones are like what you eat, what you drink, your activity level, whether you're physically active or sedentary in nature, they come into it. And if you're an alcoholic, it's also a lifestyle. If you eat and what you take in is also a kind of lifestyle. So we advise usually that if those factors that we put in place to control obesity, also comes into play in control of diabetes, because a major predisposing factor is obesity. And those factors we put in place to also control hypertension also comes into play, because like diabetes and hypertension are almost like a
brother and sister,
yeah. So we advise generally that when it comes to eating habits, we can't say don't take carbohydrates or sugar containing foods, because it forms a bulk of our staple food. But we say when you take them, it has to do with some degree of moderation, and let it not be something that you take all round, nothing to mix it up, like taking fruits and vegetables from time to time, taking proteins to make the diet actually adequate, like what we call adequate diet. And if you don't overload your system with so much carbohydrate, so much refined sugar, then you reduce the load on the pancreas, and it's not likely to get worn out within a short time. And also, you increase your activity level. Physical exercise has a lot of role to play in putting diabetes mellitus at abeyance. So if you are physically active, you are not likely to come down with diabetes mellitus on time, even though you may have the potential.
Okay, so I understand that there are two types. There's type 1, type 2. Some say type 2 is more dangerous. Is that correct?
Not really. Type 2 is commoner.
Which one is type 1?
It's commoner. Type 1 is the one that is insulin dependent.
Okay.
You know, let me make it very clear that when I mentioned pancreas, you know, the problem, the major function of pancreas, amongst other functions, is to produce the chemical called insulin from the islets of Langerhans, a cell inside the pancreas. When you produce insulin, that insulin has the function to moderate or modulate the glucose level in the system. So if the organism, the organ becomes deficient in producing insulin, then the control of blood sugar in that individual becomes defective. So for some people that are born innate nature in the pancreas to lose the ability to produce insulin, you know, the cells are either damaged or not well formed. You know, they are not able to produce their insulin right from birth. So that means from birth they are already diabetic. You know, their system cannot control blood sugar. So those are the ones we refer to as type 1 diabetics. Type 1, primarily they are diabetic, you know, from birth. So those ones, the major treatment is to give them synthetic or artificial insulin. Right from birth to do what the natural one would have done, which they don't have. So the treatment for that one, it's a bit more technical, and usually we advise that a specialist, maybe an endocrinologist, at least initiates the treatment.
Okay, just before we look at the types, because of time now, some say that continuous intake of the insulin as a result of type 1 diabetics, that it has its own side effects, that over time there's this tendency to have you know, cataracts in the eyes and all that.
Well, honestly, you know, the insulin that you use to treat type 1 diabetes is not the natural one, even though it may mimic the natural one. You know, you may get it from other animals or whatever, but it's not the human.
So there is effects.
100%. So there's very likely to be some side effects.
What are those side effects?
There's hardly any medication you take without side effects.
Side effects.
You understand? But the major thing, the major side effects we point out to patients, you know, is the likelihood to go into hypoglycemia, which is common with insulin treatment. So all those other complications, we don't.
The hypoglycemia, is that synonymous with the cataracts in the eyes?
The cataracts in the eye is not synonymous with hypoglycemia. A lot of things can lead to cataracts in the eye, and insulin intake is not even #1 cause. So we don't scare patients with that. You understand? You can take your insulin for several years and you will not come down with cataracts.
Okay, let me pause you. I want to come to you. Dr. Bazwai, one more time on pathology. Now, the bone marrow transplant. The fear for this is that it's expensive. I remember I've had you like 2-3 times on this same bone marrow transplant. One would have expected that by now it should be cheap, because a lot of people live with the sickle cell anemia.
Yes, you know that the problem about medicine or high-tech medicine in developing country, because hitherto in 2009 there were publications that you can't do transplant in developing countries because of the problems. And let me also say too that the cost of transplantation is actually heightened by the fact that we don't manufacture any drug. And also too that the power to generate power to run the transplant room for 2 to 3 months when the patient is there is also a big problem. So take, for example, where you have to power the section where you are doing transplant for about 3 million naira within 3 months, because you have to use diesel. So you discover that part of the cost is into power generation. The second cost is into importation of drugs. So the government must take a proactive measure by ensuring that these things are available. Drugs, for example, you need to talk about reducing tariffs for drugs that are imported for transplant. That's what India did. For medical tourism, India gives out loan to medical doctors who want to establish this thing at 1 digit. Power is not a problem. Drugs are also now manufactured in India. You have big companies who are manufacturing drugs in Europe having their companies in India. So
India.
summarily, that's the major cost. But it's still the cheapest in the world. Because in Europe, for example, transplant will cost you about $200,000. So if you compare that to what we're doing,
It's millions.
it's still, yes, but it's still beyond most average Nigerians, and we expect that government must take a proactive action.
Now,
As I said,
for treating the sickle cell anemia, perhaps in developing nations like Nigeria, we understand that there are lots of side effects compared to what is obtainable in some other climes. Say, for example, I've actually seen a sickle cell patient that the hair had to fall off, the teeth, you know, have to fall off and all that.
well, that may be a complication of the disease itself, but not bone marrow transplant.
Okay, the bone marrow transplant does not have a side effect.
It does have side effects.
What are the side effects?
But this patient you are talking about is not.
What are the side
Yes.
effects?
Okay. Well, let's remember that today is World Pathology Day.
Yeah, but
and then the theme for today is we all need the pathology.
okay.
So, but now you're talking about sickle cell generally, which is also
No,
being
there's no
done.
way we talk about pathology that we can't
Yes,
talk
I know,
about.
because the bone marrow transplant is being done by a pathologist.
Yeah.
It's one of the areas that we do in pathology. The side effects for bone marrow transplantation worldwide is that you have about 5% mortality. Because it's high-tech medicine, anything can go wrong. But we've been lucky in Nigeria. We've done 8, and we have 100%. All of them are all alive, so we don't have mortality.
Now, what is the theme of the pathology day again today?
We all need
The
the pathology.
pathologist. Okay. Okay.
So what we're trying to say is that there are a group of physicians who are pathologists, who are doing a lot of work in trying to bridge between the result that comes out from the laboratory and the clinical part.
Okay.
And we have very many. Nigeria has a lot of pathologists
Of
now.
which you are one of them.
Which are, yes, of course. And one of the areas we are working on is including bone marrow transplantation we mentioned, but also there are people who do a lot of autopsies on a daily basis.
Okay.
These are pathologists. And apart from working in the lab, we also see patients. We have clinics, we review both. So if I start managing a patient, for example, I have the privilege of looking at the patient samples in the lab and collaborating with the patient and coming to treat the patient.
Dr. Bazwa, now quickly, the type 2, just 30 seconds because of time. Type 2.
Yes, type 2 is the non-insulin dependent.
Okay.
That one, the body produces insulin, but somewhere along the line, it becomes inadequate. At the onset, mere lifestyle change, a behavioral change and all that may be enough to control the level of sugar.
Okay.
But if that becomes inadequate, we give tablets, drugs, without necessarily going down to insulin.
Okay.
It's when it becomes complicated and very, very acute that we may introduce a little insulin. Okay. So type 2 and is much more commoner, and it occurs later in life.
Okay. All right, gentlemen, I really need to apologize because of time factor here. We really need to say a very big thank you now on this.